So good morning, everyone, and welcome to the first webinar in a series of 4 that we are delighted to be hosting with Welby Assist. As a lot of you know, we like to put on webinars throughout the year, not only directly around finance, but also around other very important areas that, of course, do have an ultimate financial impact on practices. So today I'll be covering some key points to remember in respect of the pension certificates and estimates form, and then I'll be welcoming Chris Jarvis here, who will be covering the first of the WE statements, SAFE. Next week, Wednesday the 28th, Chris will be covering the second WE statement, caring and responsive, and our head of payroll, Damon Tunnicliffe, will be giving a payroll and pensions update. On Tuesday the 5th of March, Chris will cover the third WE statement, effective, and our ESG lead and assurance director, Sally Ann Hearn, will be speaking about ESG. The final webinar on Wednesday the 13th of March will cover the well-led WE statement, and Heidi Thompson, our HR director, will be giving an HR update. You do have to sign up for each webinar separately, so if you haven't already and are wanting to join us for the next 3, then please do sign up. So it's February, the time of year when there's a flurry of excitement as GP partners await their Type 1 certificates for approval, and salaried GPs generally panic about having to complete theirs. Then, of course, we have the estimates form to complete for next year. As you may know, the deadline for submission for the certificates and the estimates forms has been extended to the 31st of March 2024. And the reason for this is that the Type 1 certificates only came live on PCSE Online late last week, and the estimate form still isn't live, leaving it absolutely impossible for accountants to meet the February the 29th deadline originally given. GPs are, however, already receiving emails chasing the certificates, so do rest assured if they are getting chased, it's not because the accountant has been dragging their heels with the preparation, it is because they couldn't prepare it any sooner. If you are one of our clients, the certificates are in hand now. The form has gone live, so you can ignore the chasers. The Type 1 certificates are usually prepared by the practice accountant. There have been numerous issues with certificates and unnecessary rejections over the last few years. And as a member of the Association of Independent Medical Accountants, I can confirm that we do have regular contact with PCSE to raise concerns and request changes to accountant access and the system in the hope that things will improve. If you are a GP partner listening and you have solo income, this is an area that often causes issues. So please do ensure that you keep copies of all of your solo forms and that these are passed to the person preparing your Type 1 certificate. If any partner has difficulty approving their certificate, and we have seen issues, particularly with retired partners or non-GP partners, it is possible for another partner in the practice to approve their certificate for them. A key point I wanted to raise this morning was in respect of the Type 2 certificates for salaried GPs. On almost all of our practice accounts who employ salaried GPs, there are differences between the amounts deducted by PCSE from the practice and the amounts deducted from the salaried GP's payroll. These differences should disappear once the salaried GP has submitted their certificate, but what we often find is that some salaried GPs aren't completing them, and so these differences can date back for a number of years and are just sitting in the practice accounts as a difference. Certainly for our clients, the figure shown in the profit and loss account will be what should have been taken from you, so usually the payroll figure, unless there had been any change in circumstances that impacted their tier rate. The difference will be carried forward on the balance sheet. So what this means is it ensures that the account's profits are correct each year, regardless of what's happened with the actual cash payments. We strongly recommend that practices remind all of your salaried GPs that they need to complete this form, and to avoid any errors, provide them with the pensionable pay figure for your practice payroll for each year. And I know Damon will touch on this next week, but he certainly has the figures for the pensionable pay for the salaried GPs and the practices that we do the payroll for. We have seen issues with salaried GPs using their taxable pay figure, which is much lower than the pensionable pay figure, because the taxable pay figure is after deductions of the employee pension. PCSE do not know that this is not the correct amount, and so in these cases we have seen large refunds. We have had a couple of cases where practice managers have asked how the refunds should be paid to the salaried GPs, which has fortunately enabled us to step in and advise that the certificate is incorrect and get it corrected. Another common mistake is for the salaried GPs to use their gross pay figure. Whilst in many cases that may be the same as the pensionable pay figure, in some cases the gross pay may also include reimbursements or bonuses that don't attract pension. This is why we recommend you pass them their pensionable pay figure. Moving on to estimates forms, this is where we submit an estimate for the pensionable pay for all partners and the pensionable pay figure for salaried GPs for the coming year. This is what PCSE base their deductions on. Some key points to remember are that the pensionable pay figure needs basing on all of the pensionable income for any GP partners. For salaried GPs, the pensionable figure will be the pensionable pay from your practice, but you also need to know if they have any other pensionable pay from other sources that may impact the tier that they're in. It's really important to get the tier as accurate as possible, because if a lower amount is deducted from payroll and the tier at the end of the year is higher, it will be the practice that have the additional percentage for their pay element deducted. And that's fine if they're still with you and it can be adjusted, but not so easy to claw back if they've moved on. Remember, the percentage deducted by PCSE and the percentage deducted from payroll should match. Another flaw in the system. It used to be that the GP sent payment themselves with the certificate in the good old days of paper. Just check it out. It's okay. There's some beeping on my machine. I was just checking everybody could hear me, but it looks like they can still. So yeah, in the good old days of paper, they used to send the paper copy in and they used to send the payment with them. A reminder that the form needs updating throughout the year for any uplifts to salaried GP pay. So remember, it's not just a form that needs completing at the beginning of the year, it does need updating throughout the year for any changes. And also a reminder to let the accountants know if there are any changes to partner sessions during the year or anything significant that happens that might impact on pensionable profits, such as significant changes in income or expenditure, or any capital expenditure as well, any large capital expenditure. And finally, for my session, a few tips and hints. So joiners. We have seen a lot of issues with joiners not appearing on the estimate form, and so deductions not being taken. A common problem is that the SD number doesn't come through. If it doesn't come through, you can't overtype it. You have to raise an enquiry and pop the SD number on there, and then PCSE will process. We have seen this being dealt with much quicker in the last month or two because there have been numerous problems in the past, which has caused a lot of problems. The other thing that has improved is that previously they wouldn't backdate deductions. You had to raise a separate enquiry for backdated deductions, but now they will deal with these based on the joining date, so one step less to complete. Before you can complete a joiner form to start pension contributions for a GP who has started working at your practice, remember the GP needs to log into PCSE online and update their employment details in the performer list section. Once the GP has submitted the employment update, it's sent to the practice user with the PL practice manager role to approve it. Submissions by new partners also need to be approved by ICBs. Once the employment update has been approved, the practice user with the GPP joiners and leavers role needs to complete the joiner form to confirm the GP's estimated income and tier rate to start the deduction of pension contributions. For non-GP partner joiners, before you can complete a joiner form to start pension contributions for them, you must ensure that they have been assigned the GPP non-GP partner role by the practice user administrator and that their pension scheme membership number, the SD number, has been attached to their record by PCSE. The practice user with the GPP joiners and leavers role needs to complete the joiner form to confirm the non-GP partner's estimated income and tier rate to start the deduction of pension contributions. Finally, leavers. The practice user with the GPP joiners and leavers role needs to complete the leaver form on PCSE Online as soon as they know a GP or non-GP partner is going to leave the practice. This ensures that the pension contributions are stopped from the date the GP is leaving. If anyone has any questions, then please don't hesitate to contact us. There will be feedback forms sent out at around 11:15 today, so please do fill these in and add any comments and questions on there, or ask your usual Duncan and Topless contact. I now have pleasure in welcoming Chris Jarvis. Chris is a former CQC inspector and brings a wealth of expertise in healthcare regulation and quality assurance, having dedicated 11 years to the CQC as an inspector. Throughout his tenure, Chris played a pivotal role in ensuring and evaluating the standards of care provided by healthcare organisations. His commitment to upholding and enhancing the quality of healthcare services has made a lasting impact. His extensive experience as an ex-CQC inspector has equipped him with unique insights into the intricacies of compliance, allowing him to provide valuable perspectives on how organisations can meet and exceed regulatory expectations. Beyond his regulatory expertise, Chris is now dedicated to sharing his knowledge and insight with others, whether through mock inspections, staff education, or hosting webinars. Chris continues to contribute to the improvement of healthcare quality by empowering individuals and organisations with the information they need to navigate the ever-evolving landscape of healthcare regulation. So thank you, Chris, for joining us today, and I'll hand over to you.
Thanks for bigging me up, Kate. If you can write me a reference, that'd be really good, actually. As Kate said, I worked for the CQC for 11 years, primarily in primary medical services, with a special interest in out-of-hours NHS 111 and urgent care services. I retired in September of last year and have now taken this role on to try and share my knowledge with those people that wish to know. I thought I would start just by talking about the CQC generally, where it was and where it is now, because there have been massive changes over the past year and a half, 2 years. So prior to April 23, last April, 10 months ago, the organisation was split into 3 directorates, basically. So that was Hospitals Directorate, the Adult Social Care Directorate, and Primary Medical Services, which included dentistry and independent healthcare. And that meant that there were dedicated teams of inspectors who just dealt with their particular field. In April 23, there was a reorganisation. So across the country, the regions were changed, and Lincolnshire, Nottinghamshire and Derbyshire is now a hub within the Midlands region, which is headed by a director and 2 deputy directors. But the teams, the inspectors across those 3 directorates I mentioned a minute ago, have now been put into multidisciplinary teams. So, for example, I'm going to talk about, I know there's probably people on here not from Lincolnshire, but I can only talk about Lincolnshire that I know intimately. So in the Lincolnshire, there are now 2 teams headed by an inspection manager. 1 inspection manager was from primary medical services, 1 from adult social care. And each of those teams, there is a mix of primary care inspectors, hospital inspectors and adult social care. Of course, adult social care was the biggest directorate, and so all those teams are loaded in favour of adult social care. Having said that, there is very little cross-sector working, so the adult social care inspectors look after adult social care, and the primary medical services look after primary medical services. So that's not changed much. The only difference practically is that reports that inspected right aren't necessarily reviewed and approved by somebody with knowledge in that particular sector, but that's their decision. So that's a reorganisation of the organisation itself. What has changed and what concerns the people on this call mainly is the change in the inspection process. So I'm not going to use the word inspection anymore because that's gone. They're now called assessments, and they follow a thing called the Common Assessment Framework, which was introduced to try and ensure that when inspecting services across an area, so it might do an inspection which includes primary medical services, but also adult social care and secondary care, they could use the same evidence categories to assess those services as a whole. That was the idea of it. So now I'll just go back a bit about these teams. So prior to April last year, every GP surgery in England was allocated to an inspector. So, for example, in Lincolnshire there was 3 inspectors, and I had the practice in East Lincolnshire, the old East locality, and some in the other localities, but primarily East. The other 2 inspectors looked after the practices in South, Southwest and West. That has gone now, so there is no inspector has a portfolio of practices on their list. So what it means actually is that unlike previously, there is no point of contact for practice managers. I mean, we always, for many years, but tried to build up a good professional working relationship with practice managers and the practices and the partners if possible, so that when there were issues or matters need discussion, we could pick the phone up and have a discussion with somebody we knew and we could trust, and they could trust us, and we could come to some agreement over it. That's not the case now. All that has been taken away, so there is no day-to-day contact possible between a practice and anybody at CQC. All requests for information or assistance will have to go to the portal, and it could go to anybody to deal with. Likewise, prior to that, all inquiries or complaints that the CQC received were dealt with by the inspector who held a relationship with that particular practice. That's no longer the case. Instead of there being sort of 9 or 10 inspectors to cover the Lincolnshire, Notts and Derby area hub, they call a hub, there's now just one person, one inspector, who's now called a regulator assessor, who is receiving all those inquiries and complaints and trying to deal with them in totality. So it's one person dealing with what was a 300 practices. I would imagine there's 84 in Lincolnshire, I think 120 in Notts, something like that. So probably 300 in total, and there's one person being expected to do all that. Whether that will work or not remains to be seen. I have my own views on it, but that's that. So that's where we are. So getting down to what we're going to talk about, these we statements. First and foremost, I need to say that the regulations on the Health and Social Care Act have not changed, and there is no prospect or no thought of them changing. They are primary legislation, and to do so would need an Act of Parliament and a lot of time. So there's no thought that that's going to change. There have been some slight amendments to them through statutory instruments to allow the inspection of local authorities, which wasn't possible before under the Act. But the actual regulations themselves remain as they were. And all practices need to meet the requirements of those regulations. Now, the evidence, we read about we statements and this and that and the other. They are merely statements. They are statements. the evidence you need to meet the requirements of the legislation, of the regulations, hasn't changed one bit. It's just the same. And how you collect that, how you meet those requirements is a matter for you. The CQC has never dictated or prescribed how you need to meet those requirements. It's a matter for the individual practice to meet those requirements. And all practices, well, not all practices, many practices do it very differently from others. That's the way it is, and that's what they expect from individual businesses. So there's the we statement, and I'm going to talk just about primary medical services, because each category of each sector, healthcare sector, has its own evidence categories. I mean, the categories, no, that's not true. The evidence categories are the same, but what an inspector will look at when they do an assessment of your service is different depending upon the sector it falls in. So it's a bit complicated, but the actual evidence categories are people's experiences of health and care services, feedback from staff and leaders, feedback from the partners, observation, process and outcomes. Now, when we're looking at primary medical services, out of those 6 evidence categories, not every category will be looked at in an assessment when an inspector does an assessment of your service. So, for example, one of the we statements is about learning culture, and I'll just read it because it comes under the safe category, and it says safe key question. It says we have a proactive and positive culture of safety based on openness and honesty, in which concerns about safety are listened to, safety events are investigated and reported thoroughly, and lessons are learned to continually and identify and embed good practice. So for that particular we statement, if an inspector was coming to do an assessment of your practice, in getting evidence to meet the requirements of that we statement, they would only look at 3 evidence categories, and that would be people's experiences of health and care services, feedback from staff and leaders, and process. So feedback from staff and leaders would gather through interviews with staff on the premise or before or after the assessment day. People's experience of health and care services, that includes open source data such as the National GP Survey, complaints received by the CQC, complaints and information that have been received by the ICB and that sort of thing. And process talks about the process of has the practice got in place a system whereby learning from, for example, complaints and from significant events goes through a process of investigation, evaluation, and the learning identified being cascaded to staff to try and avoid any reoccurrence. In the safe key question, and the key questions the same as always were: safe, effective, caring, responsive and well led, although we put in different order, which use the acronym SCREW. But so in that safe key question, with the we statements relate to learning culture, safe systems, pathways and transitions, safeguarding as you'd expect, involving people to manage risks, safe environments, safe and effective staffing, infection prevention control, so, and medicines optimization. So they are a little bit different in as much as formerly staffing would have fallen in effective, but it's now moved into safe. So there's been some change in the way they're doing it. But what you need to imagine, what you need to remember is, going forward, is that there's no such thing as an inspection. They're now called assessments, and as far as the practice is concerned, you are very, very likely to get more frequent assessments, which may well include on-site visits, but could be done off-site. So if the information is available through all the sources without doing an on-site visit, then they will try and do it that way. But the other thing to remember is that, you know, whereas CQC always tried to give a minimum of 2 weeks notice of an inspection, assessments are not like that. Assessments are most likely very, very short notice or no notice at all. So the likelihood is that they will just pitch up at 8 o'clock on a Monday morning, say thank you very much, we've come to look at this. So that's about, and that most of those assessments are going to be generated by perceived risk, and that could be anything. That, you know, the regulator assessor in Nottingham, if they get lots of complaints about, I don't know, no GP availability or trouble with access, or not making it through the phone, or a whole number of things, or medicines problems, or dispensing errors, or whatever it might be. There'll be risk-based assessments, and there's likely to be more of those. So people have not had an inspection for 5, 6, 7 years in some places. You can expect assessments on a pretty regular basis. And the idea, and I think the idea is right, because some of the ratings are very, very old and probably not relevant or as relevant as they were when they were first done all that time ago. So the idea is that there'll be more frequent assessments, which will result in a better understanding of quality and a more realistic overview of what the service is actually like, rather than what we think it was like 5 or 6 years ago. What I will do, I think the best thing is I will get the links for the WE questions and the categories. Oh, okay, and categories. Okay, and I'll get Duncan Topless to stick them in the link and send them out to all the participants, all the people who said they were going to attend this webinar. I could go through all the WE statements, but it would be, you know, pointless really. It's better if you read them yourself. But of course, I'm happy to take any questions and enter into any sort of correspondence with people about them if they've got concerns. Just bear in mind that when you do read them, you'll get the impression that a lot of them aren't relevant to primary medical services, and you'd be right in some ways, in as much as they were written in the main by people involved in adult social care. So a lot of it sort of, you know, infers that these people are in residential settings, but, you know, that's the way it is. On a practical point of view, those practices that are new registrations and have not been inspected up yet will have an assessment. I never use the word inspection. We'll have an assessment shortly, within a few months, which will be an assessment of all 5 key questions, as used to be the case, and the evidence categories related to them. So you need to be aware that that could happen any time at very short notice. The other thing to be aware of is that formally, inspectors used to send out a thing called a pre-information request, which is a request for information. Those of you who went through an inspection will know we asked for information about safeguarding and infection prevention control and staff numbers, staff training, when you're open, how many appointments you're offering a day or a week or a month or whatever. It's unclear whether that's going to be still the case. The thought is that there'll be no pre-inspection request for information, and the inspector will merely descend upon you in the morning and expect you to have it at hand there and then. Yeah, what else? So that's new registrations, if you like. Those haven't been inspected yet. Assessments are happening as we speak on a restricted basis. I think there's been 2 in Lincolnshire that I know of recently using the new methodology, the new WE statements and evidence categories. However, the reports haven't been published and won't be published for the time being. In fact, throughout the whole country, across all 3 sectors, if you like, the adult social care, hospitals and primary medical services, since this has been going, which started down in the south in October last year, only 2 reports have been published. And that is because the hierarchy within the CPC acknowledged that there are what they call process issues with what's happening, and so they've blocked the publication of any more reports till that's sorted out. I don't know what those process issues are. I'm not privy to that, but I guess when they're sorted out, there'll be a rash coming. There are only 2 reports that have been published, and they were in October, and they're both adult social care ones. They're very difficult to read and understand, actually. So I can't point you or signpost you to a primary medical services one because nothing's happened. There hasn't been one published. So that's about me, I think. Thank you. Questions?
Yeah, has anybody got any questions? They want to type them up into the chat screen. We can see that somebody has asked if a copy of the presentation will be available, which is probably just crossed with what you've said, Chris, because you said, yeah, we can send that out. You're happy for us to send that out to all of the attendees.
I can send it out, Kay, together with the links to the documents that I need to read, supporting what we've been talking about. That would be useful, I think.
Yep, super. Okay, we can send those out. No problem. Has anybody got any more questions that they want to type in the Q&A section? If not, Chris will be happy if you put them in the feedback, anything in the feedback form, then we can pass those to Chris and he can get back to you. Well, thank you very much. It stunned everybody into silence. Well, thank you ever so much for that, Chris. Very interesting. So I think the key message is to ensure that you're well prepared in case they suddenly appear on a Monday morning.
Yeah.
And
I think that is the overriding message, actually, that you can't rely upon having 2 or 3 or 4 weeks notice of an assessment. It's more likely than not that it will be on the day that somebody will turn up and expect you to have the information to hand, and that's not easy, is it? It just means, like you say, you need to be very, very well prepared, better than you ever were.
Yeah. I am aware of one practice that was saying that suddenly it was we're coming tomorrow. So
yeah, I'm sure you are.
And also if you've got any enquiries or complaints, with one person looking after about 300 practices, don't expect a quick answer.
Absolutely. Yeah, right.
We've got another question just popped up. Do you know how the practice will be contacted to inform them of an assessment?
Well, if it's on the day one, they won't be contacted, will they?
Yeah.
But otherwise, it will be a phone call. But what happens is, I'll just talk through the process a little bit, that this assessor, who's actually domiciled in Nottingham, will get some information. If they find something that is of concern that they think needs some further looking into, they will contact the inspector who lives in the area to which the practice is located, and they'll have discussion about whether an assessment can be done without a site visit or whether a site visit is required. And a good example is ones relating to whistleblowers, actually. So if it can be done off-site, that'll be it. But if it requires an on-site assessment, on-site visit, then the inspector who's been allocated the post will contact by phone, I would imagine, providing the assessment is one that can have some notice to it, otherwise it won't know.
Yeah. And another question, are they trying to catch us out, Richard?
I don't think CQC ever tried to catch people. I mean, it's an odd thing, isn't it? I never tried to catch people out. When I was an inspector, I always told people, and I was sincere about it, that I went and did inspection, hoping for the very, very best for the practice and for me, because it's a lot easier to deliver good news and have a good inspection than it is have a bad inspection and deliver bad news.
Yeah.
And I mean, that's not to say that if things are wrong, I wasn't robust in telling people things are wrong and they need to sort it out. But I was pragmatic enough to say, well, if you sort it out on the day before I leave or in the next 48 hours, that'll do. You know? So it's not for catching people out. At the end of the day, the Regulations and Health and Social Care Act is an act of Parliament, and providers have got no choice but to abide by the act of Parliament, and it's as simple as that, isn't it?
Yeah.
The CQC is a regulator of all healthcare across England, and it's got a statutory duty to ensure the regulations are complied with. So I'll make no excuse or complaints about that. That's the way it is, isn't it?
Yeah, and you're getting a true picture, aren't you?
There's no different from HMRC, is it? And they're loved as well, aren't they?
Yeah. I've got another message saying, will it be an email to registered manager, and will it say what areas are being looked at? I suppose be email or telephone.
Okay, so if there is some notification of the inspection, the point of contact is the person who is recorded in the CQC official records as the point of contact. And in some cases, it's the registered manager, which may be the GP, a GP, or the senior GP if it's a partnership. If it's single-handed practice, that person will likely be the sole proprietor. But some practices have a nominated individual, which is generally the practice manager. So it depends, but they can that notification should only really be made to the person who is recording the official records of the CQC as being the person to be contacted. So it's either the registered manager, if it's a partnership or a limited company. If it's a sole trader, a single-handed, it'll be the single-handed GP, or if they've taken the option of nominating another individual, the nominated individual.
Okay, thank you. And what happens after the assessment now?
Well, just the same. The assessment, once they've gathered evidence and chewed the fat on it, they'll decide upon a rating. The ratings are the same. So you've got outstanding, good, requires improvement, and inadequate. They haven't changed. The way of calculating, there is an algorithm that looks at some of the information that's held, factual information like childhood IMSS data and screening rates and things like that, which generates a score. And so it generates a score, and then the assessor and the inspector who's done the on-site assessment will talk about what they found and decide upon what score the information that got gets. And I can tell you the numbers actually. So if a practice score between 25 and 38% of the maximum, it would be inadequate. If it's between 39 and 62%, it requires improvement. If it's between 63 and 87% of the maximum, it would be good, and 87 to 100 would be outstanding. But exactly how that is calculated, and it seems to me to be you're applying a subjective process to something that's objective. Like stats, numbers, percentages are not subjective process, are they?
No.
They seem to be applying a subjective process to something that's not. So anyway, but that's the way it is. So in answer to the question, they will sit down, think about what the ratings are, and the assessment will be published on the CQC website as normal when they start publishing again. That is
Lovely. Got some more questions popping up. Are there any resources to assist practices with what evidence maps to the new WE statements?
Well, in the links, I will send exactly what in the link.
Super.
There's a link a link which shows the evidence categories, and there's a link I'll send which shows which of those evidence categories are applicable to primary medical services. And then with those, there's hyperlinks which takes you to what we'd expect to see and what they'd expect to see in each of those evidence categories.
Brilliant, thank you. If they're not happy with the information, I think this probably means what if they are not happy with the information they have asked to see? I think that should possibly read.
I don't know. I'm not sure. That.
No.
Well, okay. Well,
can you just expand on that, please? The person that just popped that one up. Is the assessment done by one individual? Are they from primary care?
Right. So the answer is no and yes. So the assessment will be done by one or more inspectors. So if it's a large assessment and he's doing, there'll be more than one inspector, I'd guess. You probably get a Laurel and Hardy type thing. But when they've done it, they then liaise with the assessor who identified the need for an assessment in the first place, and they'll sort out what I was going to say is that as regard the reports concerned, providers will still get a draft report, and they will still have the 10-day period in which to make any factual accuracy comments. I mean, the original thought was that they were going down the Ofsted line, where they did inspection and the report was a report, and that was it. There was no opportunity to make any representations about what was in the report. And following, certain events regarding the suicide of a teacher, I think it swayed them away from that, and so they're retaining the option of having a 10-day factual accuracy period.
We've got one more question here. At what point will they tell you what your rating is after an assessment or series of assessments?
Right. Okay. Well, when they've done the report, the idea is that the reports resulting from assessments will be done in double quick time. On about inspectors doing 2 assessments a week, because they're going to be much shorter and more targeted. And so the report, and much of the report actually is going to be pre-populated. And so the report, when it comes out, will have 3 text boxes in it, but there's a maximum of 500 words that the inspector can fill into the free text box, which sounds a lot, but it's not when you're doing a sizable assessment. So the report should come out a lot quicker when they start publishing again. That's when. But I mean, if anybody's got any real, burning issues, you can email me. I think my email, the assist at Welby Group, is on the. Can you see the slides? Can people see the slides?
No.
All right. We'll send the link anyway. We'll send the link to.
And that'll have your details on it.
Yeah.
That's
fine. Yeah.
Are the assessors from primary care?
Are these, sorry?
Are the assessors from primary care?
Yes.
Yeah.
Yes. The assessor in Nottingham, she was a primary care inspector. She used to be my team actually. And in Lincolnshire now, I'm going to just talk about Lincolnshire to know about it. There are now 3 inspectors. They're all working part-time now, so they've got nine working days a week between them, and they're working 3 days each. But yes, the assessors and the inspectors will be primary care inspectors and assessors.
Super. Can a practice improve their own rating by providing evidence where they maybe requires improvement? Can this move them back to good without needing another visit?
I think no. Okay. Well, it would depend why there requires improvement, of course. So if it was because of very, very poor national GP patient survey data, and the following year that was much improved and it was really good, that would be, obviously a cause for celebration and a change of rating. There's real uncertainty at the moment about how those practices that are requires improvement or worse are going to be assessed to see if they've improved any. To try and, and I've spoken to 2 or 3 inspectors at length about this, and it's causing a lot of frustration actually, because they know as well as I know, and we all know that practices move on, they make the improvements, but unfortunately they're stuck with the requires improvement rating for ever more, and it makes it difficult to recruit, doesn't it, and things like that.
Yes, yeah, absolutely.
Yeah, and when it's worse than that, it can have an adverse effect on getting financing from banks and all sorts of things, can't it?
Yes, it can. Yeah, it can have a massive knock-on effect.
Yeah.
So comment on the primary care inspectors. Good to hear, because that's not been the case in the past. Someone's obviously had an experience of an inspection with someone from social care rather than primary care. Right.
Okay. Well, I don't think any circumstance where a social care inspector would do a primary medical service inspection. But what I would say is that on occasions, well, quite often really, inspectors from other sectors, from adult social care or hospitals or mental health even, asked to go out on a primary medical service inspection just to shadow it to see what it entails as part of their portfolio development. So, yeah.
Right. Okay. If requires improvement, then is there support for practices to improve as they used to be?
Tell me again.
So I think somebody's asking if their practice required improvement, there used to be support to help them move up, to improve them to good. Is that support still there?
I think it's a conversation you need to have with the inspector who comes and does the assessment on site. Absolutely.
Right.
Okay. Certainly no. It always used to be the mantra of the CQC that they were a regulatory body and not an improvement agency. The mantra has changed over the past 10 months since last April, and now you actually see written in CQC documents about driving forward improvement. And so I think there's a mindset change there, which is quite right as well, because part of regulation is improving it to make sure there's less breaches of regulations, isn't it? So so I think it's a positive thing, but I think where practice requires improvement, then it needs to be a conversation with you and the assessor and probably the CCG to work collaboratively, and the LMC, of course, to try and move that forward. I know if Nick's on the call, he probably is. He'd probably kicking me when he sees me.
Somebody had asked if there would be a recording of this webinar available, and yes, there will be a recording available at a later date. It'll be released, so you'll be made aware of that. And then somebody else has said, I think RCGP used to provide the support in the past, talking about patient care, improvements to patient care and RCGP.
Yeah.
And so, I suppose at the minute, your role at the minute with Welby Assist, you're obviously going into practices and supporting, aren't you?
Yeah, I went to one yesterday and did a mock inspection, if you like, at one yesterday, which went very well. So if anybody wants, some assistance, as we said early on, the thrust now is that you need to be prepared for your for your assessment in advance, because you haven't got time. You haven't got that 2 or 3 week period of grace between an assessment being announced and actually happening to put things right that maybe not so right, and with the best, in the very, very best practices, I can guarantee there'll be some hiccups and some glitches somewhere. I mean, I know that, and I wouldn't be doing my job if I didn't find them, but that's what I'm there for.
Yeah.
Anyway.
That seems to be all the questions that have popped through. Yeah, that's all that's come through. If anybody does have any more, as we say, there'll be a feedback form coming out in about half an hour, so look out for that coming. There'll be the links being sent out. There will be a recording at a later date that you'll be made aware of. So any feedback on today's sessions and any questions that you've got, please just pop those on the feedback form or email them in to us. So thanks ever so much, Chris, and we look forward to seeing you again next week.
All right, mate. That's good. Thanks very much.
Super. All right, take care. Thank you, everybody, for joining, and we'll look forward to seeing you all next week.